Welcome to CE Conversations, a clinical podcast presented by Creative Educational Concepts, designed to improve clinician performance and optimize patient outcomes. This session, entitled Targeting Unmet Patient Needs in Diffuse Large B-Cell Lymphoma, Emerging Strategies for the Interprofessional Healthcare Team, is accredited for 1 hour of ACCME, ANCC, and ACPE credit, and supported through an independent educational grant from Genentech. To earn CE credit and complete the evaluation for this activity, please visit the link in our show notes at the conclusion of the podcast. And with that, we will turn it over to our expert faculty.
Thank you. Thank you for joining everyone out there. And I appreciate the time to come and listen to this lecture and get some CME credits and some education on this important topic specifically about treating diffuse large B-cell lymphoma. It's a evolving landscape, particularly in the relapse setting, but these new treatments that we have will be trickling further and further into frontline without a doubt, and we've already made some changes that we'll learn about tonight. So this is looking at targeting the unmet patient needs in diffuse large B-cell lymphoma, emerging treatment strategies for the interprofessional healthcare team. Here, this is who I am. I'm an assistant professor of medicine here at Weill Cornell in New York City. I am a lymphoma physician. I see a lot of patients with DLBCL as well as other lymphoid diseases like CLL and other indolent histologies, and have been doing this now about 8 years, and specifically in this lymphoma space at Cornell. All right, thank you for that. So now we'll move on to the lecture. So this is the current landscape of DLBCL, and this is going to summarize kind of how we got to where we are and what we're doing now as the standard of care. And then we'll talk later about the importance of this frontline therapy and then the new regimens that we might be using in the future. So diffuse large B-cell lymphoma, also known as DLBCL, is the most common non-Hodgkin lymphoma, represents about 30% of NHL cases worldwide. There are about 150,000 new cases of DLBCL annually or so, and that's worldwide. And in the U.S., there's probably about 100,000 cases or so of non-Hodgkin lymphoma, which about 30,000 of those are DLBCL. So patients are commonly present with progressive lymphadenopathy, extranodal disease, and require aggressive therapy with immunochemotherapy. This is not something you typically watch and wait. Patients present because they are sick. Things were fine 2 months ago, and all of a sudden this lymph node continues to grow and is becoming problematic, painful, or worrisome, and patients are not feeling well with other B symptoms, etc. So patients need treatment typically soon after they are diagnosed. For nearly 20 years, rituximab, Cytoxan, doxorubicin, vincristine, and prednisone, or also known as R-CHOP, has been the standard first-line treatment for DLBCL. This is the common regimen that we use and the doses there. Importantly, this is an outpatient regimen given all in one day in our infusion center, and it's given every 3 weeks. These patients come in. It is an all-day event. They see the doctor before, get blood work done, talk about any questions, side effects they may have, go on over to the infusion center. And obviously with rituximab given IV frequently, you have long infusion days, at least 3 to 6 hours, depending on which cycle you're in and how well the patient tolerates the rituximab. The other doses go in rather quickly, but regardless, to say that, having your labs done, seeing the physician, the pre-medications that need to be done, and the infusion times, it's regardless a 6 to 8 hour day for our patients. And that is repeated every 3 weeks on an outpatient basis commonly. The GILA study evaluated the benefit of addition of rituximab to CHOP, and it's in elderly patients, 60 to 80-year-olds with DLBCL. And the response rates for our CHOP compared to CHOP were 75% for the CR rate compared to 63%. And progressive disease, primary refractory disease, is 9% versus 22%. And then death during treatment, the addition of rituximab didn't seem to add too much toxicity necessarily to the therapy, and all of these were statistically significant. The other studies that have been done in younger patients, also the Mint study showed improved 3-year outcomes with the addition of rituximab to CHOP-like regimens in young patients, with good prognosis of DLBCL, and the event-free survival favored those getting the rituximab chemotherapy. As you can see there, 74% EFS versus 55% EFS in these younger patients. For those patients with limited stage disease, S1001 found that 4 cycles of R-CHOP alone could be equally as effective as 3 cycles of R-CHOP followed by radiation. And the 5-year PFS for these low-risk patients was 87%. Overall survival was 89%, with patients having similar outcomes between the two groups. And so, we used to think that we had to give chemo therapy plus radiation, and we found that we can give chemotherapy alone in limited stage disease, and several studies have shown this. And thus, we limit toxicity from the chemotherapy. The radiotherapy. Radiation is not completely wrong, and we do know we can cure a lot of patients and thus limit the amount of chemotherapy given. And the SWOG study evaluated 3 cycles of R-CHOP followed by involved field radiation in patients with at least one adverse risk factor. The 4-year PFS was 88%, EOS rate was 92%. So for higher risk limited stage patients, we sometimes think we should add on the radiation. Otherwise, very low risk, low IPI and limited stage disease, typically you can get away with chemotherapy with just 4 cycles. Despite R-CHOP being our gold standard and essentially curing a significant number of patients, there is anywhere from 40 to 30% or so of patients that are not cured that do need to have second line and later lines of chemotherapy. And so, it is important to understand who are those patients that are failing the regimen. We need to do better at improving our treatment for all patients, essentially to improve that outcome. And so in general, R-CHOP is found to be inadequate in these 30 to 40% of patients. The 10-year overall survival rate is about 43, right around 50% of patients are cured essentially with frontline therapy at this long-term outcome, receiving R-CHOP alone. It's important to note that the biology of the lymphoma does dictate a lot of this. There are 2 major distinct molecular subtypes of DLBCL. There's the germinal center B cell and the non-germinal center or ABC subtype. And in general, ABC DLBCL is much more aggressive and has substantially worse outcomes when you look at, comparing to GCB phenotypes when treated with R-CHOP. We thought we can improve these outcomes by intensifying chemotherapy for these higher risk patients. But ultimately, we're not really able to do that with some of the more recent studies that have come out. So one way that can help stratify how we manage our patients and who we need to really worry about is looking at the International Prognostic Index for DLBCL, or the IPI. It's a 5-factor scoring system. And you can see here it's based on age, your stage, ECOG performance status, your LDH, and how many extranodal sites are involved. And you get a point for any of these if over age 60, stage 3 or 4 disease, poor performance status, kind of in a chair or bed bound, an elevated LDH or more than 1 extranodal site, you get a point. And based on how many of those 5 points you get, will stratify you into essentially good, low, intermediate, or high risk groups. These scoring systems have been revised based on age as well as in the rituximab era. And you can see those with the RIPI, or the rituximab era IPI. You can see it stratifies depending on how many of these risk factors you might have. And you can see it very well clearly delineates how a patient may do over the 4-year overall survival and progression-free survival, and identify how many percentage of patients we might cure with these numbers of risk factors. So very important tool, easy to calculate, all essentially standard clinical factors that you'll get at diagnosis before you ever treat a patient, and can help educate your patient as well as yourself on what the outcome might be. So what are risk factors for treatment failure in the frontline setting? So treatment failures are due to a variety of patient and cancer specific factors. Obviously, not responding to treatment is a poor risk prognostic factor, but you don't know that going in. Some patients with very aggressive disease have lymph nodes that literally melt away. The IPI index is very good at identifying how a patient may do long term, but also doesn't really stratify, a patient with 3 to 5 points against them. 50% of those patients are essentially cured. So who are the 50 that aren't cured with the same risk factor? That's what we need to do. The GCB versus ABC subtype helps a little bit, but again, you cure ABC subtypes and you don't cure GCB subtypes sometimes. So how do we differentiate? We need better scoring systems, and understanding genetics may help that. And there is some data emerging that genetic signatures may identify patients who may be more sensitive to specific treatment types, et cetera. And those clinical trials are ongoing. Death related to R-CHOP toxicities are uncommon, but this is a potent regimen, and it's not so simple to deliver to patients who are 70 years of age or older. And treatment-related mortality is usually associated with lack of response to chemotherapy, though, I have lost patients to sepsis, typically older patients not able to mobilize themselves or recognize serious signs of disease, and/or people who have ignored my calls to come into the hospital, call 911 or get into the ER. And you unfortunately hear the next day, sometimes they're found by their family members or neighbors or whoever it is. And I think it's education, it's age, it's an ability to mobilize and not adhering to recommendations by the physicians sometimes. So it is very serious. It is a very potent regimen, but for the most part, you can get through it. You can get older patients through it. You can dose reduce, and it is very effective, but it is something you need to be prepared for some of these toxicities. So relapses can be defined as early or late, and typically, while we define primary refractory disease as disease that doesn't respond to treatment or get into a deep remission in the first 6 cycles, or those who relapse within 12 months. Really, these early relapses are within 2 years of diagnosis. Late relapses are greater than 2 years. If you could cross this 2-year threshold, the likelihood of a late relapse definitely, or a relapse at all, definitely diminishes. And 2 years is kind of a threshold we like to start thinking about. Maybe we've cured the patient. Really, that 5-year mark is much more telling. Relapses can occur late, but vast majority of them do occur within 2 years. As these late relapses do respond to salvage therapy, much more so. They're a little bit more sensitive to treatment. It's kind of that one cell that was initially sensitive kind of never got cleared out and took some time to grow back. But those patients who are relapsing within 1 year of initial therapy are considered chemo refractory, and we now have CAR T cells that are approved specifically in this space within 1 year of therapy, relapse within 1 year of therapy or primary refractory disease. More chemo and stem cell transplants are not going to help those patients. This has been proven in several phase 3 clinical trials. Late responders or late relapsers tend to have these better responses. And we are thinking about stem cell transplant, chemotherapy salvage, and stem cell transplant still for these patients. So as an important question that we asked in the pretest, in a retrospective analysis, patients diagnosed with de novo DLBCL, the odds of having an early relapse as opposed to a late relapse was higher in patients with LDH, extranodal sites, but the highest in patients with advanced stage disease. So stage 3 and 4 disease had an odds ratio of 8 compared to around 3 for the other risk factors in the IPI. So advanced stage seems to be a predictor or something that associates with a higher risk of relapsing within 2 years. So if you can remember that from this lecture. Double hit lymphomas, many patients with treatment failure have double hit lymphomas. Double hit lymphoma, as a reminder, is a rearrangement specifically of MYC and BCL2 and/or BCL6 genes, but you have to have a MYC rearrangement. Commonly, it's the BCL2, but you can have, that's the true double hit, MYC and BCL2, but you can have BCL6 genes rearranged as well in combination with MYC, and that's a double hit as well. Tumors with co-expression of MYC and BCL2 are associated with poor prognosis. These are called double expressor lymphomas, but they lack the actual genetic, cytogenetic fluorescence in situ hybridization rearrangements. These are double expressors. These are typically ABC subtypes. The double hit lymphomas are typically GCB subtypes. And so that can help you differentiate these patients a little bit and identify someone you may need to worry about. The patients with true double hit lymphomas typically do get more intensive chemoimmunotherapy with R-EPOCH. We don't believe R-CHOP alone is sufficient, though we haven't necessarily proven that prospectively, as double hit lymphomas are relatively rare. And in any clinical trial prospective study, there's not powered enough to really show differences between treatment groups. But with that said, historical data suggests that intensive chemoimmunotherapy may be required to help cure some of these patients at a little bit of a higher rate than we might have if we use R-CHOP alone. The two biologic distinct subtypes we've talked about, GCB versus ABC. The GCB subtype is improved outcomes compared to the ABC with R-CHOP. We don't necessarily improve that by intensifying chemoimmunotherapy for the GCB, and not necessarily with the ABCs either. And so we used to think we might have to give the ABC subtypes R-EPOCH, but that was debunked essentially with a prospective study looking at R-CHOP versus R-EPOCH, which showed no real improvement despite the cell of origins being evaluated. Trials are still ongoing to explore if novel targeted agents can improve outcomes in these specific subsets because they are genetically distinct. They do have different genetic hallmarks essentially and mutation profiles. And we do know that these different subtypes rely on B cell receptor signaling inhibitors a little bit more so, and might be a little bit more sensitive. So studies are being designed to look at specific treatment approaches for specific subtypes. But as of right now, the standard of care is the same, and it's R-CHOP, and we'll see some later data as that evolves potentially with possible new FDA approvals coming down later this year. Disease progression in DLBCL, let's explore the burden of patients in healthcare systems. So overall survival is poor, obviously, for relapsed patients. With that said, there is about 20% of patients, 20 to 30% of patients that we can cure. As you can see on the top left here, these are event-free probabilities, and you can see if it flattens out over years, these are the patients that are cured. And you can see this is a significant period of time. This is from salvage therapy. So we're curing about 20% of patients that relapse. So of those the 50% that relapse, we cure about 20% of those patients. You can see it does, it doesn't seem to matter if you are primary refractory or relapse within 12 months of a stem cell transplant, et cetera. Outcomes are overall really poor. It does seem to matter a little bit your response to salvage treatment. If the deeper the response, the better you'll do. And whether or not you can get to a stem cell transplant can improve therapy. But this is always a little bit biased because those patients who don't get transplanted are either too frail or they don't have the response, and obviously they're going to do worse if they can't get to this outcome. But overall, we need to do better here, and we need to have newer treatments, which we do have nowadays with CAR T cells, bispecific antibodies, et cetera, that are going to be very important tools to help maybe shift this up to potentially cure more and more of these patients. So CAR T versus alternative therapies. This is kind of a review of kind of how well CAR T cell works when in salvage settings, and why we believe CAR T cells are very important and are very important in patients who've relapsed after 2 prior lines of therapy and stem cell transplant, and now in those patients who are primary refractory. The later you get in relapses, the higher number of relapses you have with DLBCL, the less likely you're going to respond to more lines of chemotherapy. The disease is declaring itself. It's very resistant. It's very aggressive, and you need novel approaches like immunotherapeutic approaches like CAR T cells. And so this is why the importance of these agents and products are there. And we've realized this, and this is just some data to support that outcomes are in fact improved in these later lines of treatment once you use CAR T cells compared to kind of beating up the patient further with more chemotherapy lines. So there is a significant cost of treating DLBCL. The National Cancer Institute places lymphoma among the top 5 cancers in terms of US national expenditure, with an estimated 2018 cost of $14 billion. All cost studies, drug cost is consistently the most significant contributor to DLBCL cost. So it's not imaging, it's not doctor's visits, it's not the infusion chair time. It is drug costs. These drugs are expensive, and they are the most significant contributors. And mind you, these studies were predating approval of CAR T cells and polatuzumab, which are also very expensive monoclonal antibodies and immunotherapeutics. And so this is only going to increase. The drug costs are only going to increase and continue to contribute to DLBCL cost burden. Given the increased incidence of DLBCL, new technologies for treating it, again, this is just adding to the rising costs. When you look at the breakdown of monthly treatment costs, claims database data from 2008 to 2015 found that treated DLBCL patients had a total monthly per patient cost of about $12,000. Over half of which was DLBCL related. The other half was non-DLBCL related. Other studies have found similar per patient month costs, anywhere from $12,000 to $16,000 essentially. So very similar. We're looking at about $12,000 a month per patient cost for DLBCL in that first year of treatment. From the first to second year following diagnosis, medical costs do decrease dramatically. Obviously, as you're curing the patient, treatments for DLBCL, 6 cycles of R-CHOP are about 4.5 months, 5 months of therapy. You do have some costs, for about 3 months after that, imaging and things along those lines and then the first few follow-ups to recover from toxicities. But once you kind of get out past that first year, costs, the effects of chemo have resolved. You're in remission, you're back to your life, there's less doctor's visits, there's less need for expensive tests, etc. And monthly costs do decrease, and why it's so important to hit a home run and potentially cure patients up front. And so when you look at this in terms of looking at total cost, the drug costs, the total cost of burden for patients receiving R-CHOP range anywhere from $30,000 to $70,000. Rituximab is an expensive anti-CD20. The average drug cost for R-CHOP is anywhere from $15,000 to $30,000. So it's close over half of the cost of a first year of treatment of a patient. And most evaluations of cost effectiveness, when you look at R-CHOP versus CHOP, R-CHOP still is more cost effective than CHOP. And this has been shown to be basically because you can cure more patients and there's less need for second line therapies, et cetera. So even though you spend more for R-CHOP, the fact of the matter is that you can cure more patients and the cost actually is decreased over time. So those patients who do require second line therapy, costs are significantly higher than those not experiencing relapse. That makes sense. And so, this highlights the importance of frontline cures and to minimize failure of our frontline therapy. So this study by Truven, by Puertom et al., looking at market scan claims data over this period of time. So this study looked at patients who did not relapse within 2 years. And this is the control group over here who received R-CHOP only, the 1,200 patients, and compared to those patients who relapsed within 2 years of their initial therapy with R-CHOP, and followed those patients for 2 years beyond that time point. And essentially what it showed is that those patients who had relapsed, year after year costs as I already showed you, the ability to cure patients is not likely. 20% of patients are cured. The vast majority of those patients cycle through treatment after treatment after treatment. So once you relapse, the cost of treatment continues basically. And you can see dramatically, logarithmically outpacing those patients who are cured with frontline therapy. So again, prior to CAR T cells here, which is going to dramatically probably double this cost, because we'll see some data here that the driver of costs now is CAR T cells, with an average overall estimated cost of about $500,000 a patient. And top drivers of those costs were adverse reaction management, ICU care, inpatient use of hospitalizations, and expensive lab tests, procedures, etc. Anytime you're using a cellular therapy, that's an expensive proposition to prepare those cells for infusion, etc. So, if you fly through treatment, you can lower the cost by decreasing your ICU care and the need for tocilizumab and some of these expensive antidote medications. But those patients who have a hard time, that cost only increased. So, it's important to think about these things, but obviously we want to do what's right, and these are the best thing for our patients. And fortunately, these are covered by Medicare for the most part, as long as they are on label. So looking towards the future, how do we appraise novel approaches to DLBCL treatment in 2022 and beyond? So the standard here are kind of the patients we need to worry about. 50 to 60% of patients are cured. We need to worry about these primary refractory patients and those who are having early relapses, essentially, and understanding how best to treat these patients. In recent years, randomized clinical trials have attempted to improve on the initial cure rates by using novel targeted agents and adding it to R-CHOP. But unfortunately, we've yet to really move the needle very far until very recently. So some studies include bortezomib and ibrutinib, others using other anti-CD20 therapy, R-squared, etc. None of them have really improved outcomes. We've looked at using intensive chemotherapy approaches, R-EPOCH, compared to R-CHOP, and that was also a failed attempt to improve overall survival, where the outcomes were exactly the same regardless of cell of origin or whatever. There was never really a subgroup that seemed to favor the more intensive chemo group. There are trends, but nothing statistically significant, unfortunately. We've tried to do different things by intensifying the regimen, by using it every 14 days and really keeping up, drug exposure on the chemo, on the cells, not allowing them to grow back versus just the standard 3-week cycle. That was failed. Adding lenalidomide, ibrutinib, maintenance therapy, using different anti-CD20s, consolidated radiation. None have really proven to improve outcomes. And so here's some data: R-CHOP 14 versus R-CHOP 21, meaning giving R-CHOP every 2 weeks instead of 3. It allows for dose intensification, essentially, and drug exposure intensification. This looked at 1,000 patients. 2-year overall survival rates were essentially the same, non-statistically significant. And while they had similar OS and PFS rates, R-CHOP 14 had much more significant grade 3 and 4 thrombocytopenia, cytopenias, etc. In a trial of 600 patients that were a little bit older, 3-year overall survival rates were 69 and 71%. Again, no improvement in outcomes and only increasing toxicity in these older patients with neutropenia, which you want to avoid at all costs if you can. Because that leads to febrile neutropenias and potential sepsis and toxic deaths. Dose intensification had no impact, was the final outcomes of these studies. Meta-analysis of 7 trials looking at this also found no overall survival difference, and therefore this idea was kind of put to rest because all it did was increase toxicities. So the role of involved field radiation as consolidative therapy is not well defined. The NCCN recommends consideration of radiation for certain patients with limited stage disease who had received abbreviated courses of R-CHOP, especially in those with bulky disease or isolated skeletal sites. though a lot of data is some studies show positive benefit, other studies show no benefit. A decent retrospective study published recently looked at 188 patients with stage 3 and 4 disease who had a CR to systemic chemoimmunotherapy. R-CHOP was the most common regimen. 68% received consolidated radiotherapy after systemic treatment, and 120 patients did not. And what you can see here is that those that did receive consolidative radiotherapy, there was maybe some benefit to those residual sites of disease after treatment, especially in advanced stage patients. But again, this was a retrospective analysis. There's a lot of reasons why somebody may or may not get radiotherapy in a retrospective manner when you're looking at it. And so you have to take it with a grain of salt. One thing that is emerging, though, is if you are responding on PETs, maybe we can eliminate radiation. So several studies have looked at this. One study, the S1001 study, looked at 130 patients, non-bulky disease with low early stage localized untreated DLBCL, got R-CHOP 3 cycles, then had an interim PET. Patients with a negative scan received 1 additional R-CHOP. Patients with the positive POT scan went and got chemo or radiation therapy followed by ibrutinib. 5-year PFS was 87%, OS was 90% with the interim PET positive patients, and the IPET negative patients had similar outcomes. So basically, if you were PET negative and your response on PET looks good, you can emit radiation. And this has been shown a few times. There's been another decent study that looked at bulky disease, and those patients that site of bulk disease was PET negative had same outcomes as those patients who received radiation despite still being PET negative and or PET positive. So I think if you are PET negative, you can probably safely omit radiation to sites of disease bulk or whatnot. But if there is residual metabolic activity in a specific site, specifically localized site after therapy, I do think there is some benefit to radiating those patients and not having to move on to consolidative, second line therapies at that point in time, as we've seen good outcomes with that radiation therapy in those patients. So we can look at alternative anti-CD20 agents. Obinutuzumab is a type 2 antibody, which has enhanced ADCC activity, antibody-dependent cellular cytotoxicity. So it activates these macrophages and NK cells much more so than rituximab, ofatumumab, and has greater direct cell death ability. So several studies have shown that obinutuzumab in indolent histologies like in follicular lymphoma or in CLL, obinutuzumab is a better antibody than rituximab. And so this has been explored with a phase 2 study looking at this in DLBCL and showed really high overall response rates, great PFS and outcomes. And it was very acceptable safety profile and very effective. So this was then tested in a phase 3 clinical trial looking at G-CHOP, or it goes by its trade name, which starts with a G, but G is obinutuzumab in this study versus the standard R-CHOP, rituximab CHOP. And you can see these lines overlap. There's no statistical significance. And so in aggressive histology, this was a negative study. Obinutuzumab was not able to improve outcomes, which is unlike what we see in indolent disease histology. So we're not able to improve outcomes with obinutuzumab. Robust, this is a phase 3 study that looked at lenalidomide plus R-CHOP, also known as R-squared CHOP, against R-CHOP in previously untreated ABC subtypes. So it's previously felt that ABC subtypes had increased sensitivity to IMiDs, particularly lenalidomide, and this looked at specifically the ABC subtypes. 570 patients were enrolled, stratified by the various risk factors, etc., and randomly assigned to R-CHOP or placebo R-CHOP. Most common grade 3-4 adverse events were neutropenia, anemia, thrombocytopenia. And so we saw some more significant cytopenias with the lenalidomide containing regimen, which is not surprising. That is one of the major toxicities of the drug. And we can see here that the primary endpoint, progression-free survival, was not met. And the PFS has not been reached for either arm. And so while it's looks like maybe at later time points it could be separating at the primary endpoint evaluation, currently there is no evidence for an improvement in outcomes. So again, a negative study at this time point. We'll see as this study continues follow-up. Ibrutinib was also evaluated in combination with R-CHOP. So this is a double-blind phase 3 study. It was called the Phoenix study. This looked at 838 patients randomly assigned to ibrutinib R-CHOP versus placebo R-CHOP. And again, it enrolled majority of patients with ABC subtypes, as the BTK inhibitors seem to have increased sensitivity in this disease cohort or subset. Ultimately, ibrutinib did not improve event-free survival in the intention to treat cohort or in the ABC subtype. What was interesting, though, is that it did seem to improve outcomes in patients that were younger. And there was increased toxicity in older patients. And so there was an overall survival and a progression-free survival benefit in younger patients. Unfortunately, the study was not powered to look at this difference, and thus it was not a primary endpoint to be looking at. And so you can't statistically say that this is the way to treat our patients, since it's not necessarily been proven. But we're back at the drawing board and rethinking these issues. And this is important data to understand to think how we design clinical trials into the future. Ultimately, though, Phoenix was a negative study overall and did not change how we practice, and we're not using ibrutinib typically classically for our patients with DLBCL. Polatuzumab vedotin is a CD79B targeting antibody drug conjugate. It's approved for relapse refractory DLBCL in combination with bendamustine and rituximab, and has a lot of rationale for use in DLBCL. DLBCL commonly harbors CD79B mutations, which actually increase the extracellular expression, or the membrane expression of CD79B, which is the target of this antibody. These mutations prevent internalization, essentially, of the protein, and thus you get a strong expression of CD79B on DLBCL cells that harbor this mutation, which is relatively common. So there's a lot of rationale to think that targeting this protein would improve outcomes. We know it improved outcomes in relapse settings. So the POLARIX study recently reported at ASH. This is a phase 3 double-blind randomized trial of Polar R-CHP versus R-CHOP in 879 patients with previously untreated DLBCL. The 2-year progression-free survival rate was statistically significant and favored the polatuzumab R-CHP arm, 77% versus 70%. There's no clinical statistically significant difference of overall survival. So it's not going to move the needle that much, but there was this progression-free survival difference. And importantly, the toxicities were essentially the same. No major changes, maybe a slightly higher numerical febrile neutropenias, maybe slightly more anemia, but we didn't see more neuropathies or any other important high-grade adverse event by addition of polatuzumab. And so you get kind of the same toxicity profile, yet you can improve progression-free survival. And many of these people who get cured up front, if we can move that needle just a little bit, that may have long-term impact on economics, as well as obviously patient exposure and their treatment course thereafter. It's meaningful for those 8 to 10 patients out of 100 that you treat to potentially cure those patients. So here is the curves. It's not super impressive, but yet to me, any patient that we can cure frontline, and typically progression-free survival has correlated to that. It's maybe a little early to call the overall survival. The median follow-up was a little over 2 years. Also, we've got really good salvage treatments nowadays with CAR T cells and things like this that didn't exist just a few years ago. And so maybe that's why these curves or overall survival are still stuck together at this point in time because those patients who progressed on R-CHOP are being salvaged essentially with these newer therapies. But remains to be seen. Ultimately, it was a positive study. It met its primary endpoint of improving progression-free survival, and likely will get an approval and may be a new treatment approach that many doctors are using across the US. The role of maintenance therapy is well defined in other types of non-Hodgkin, but less clear in DLBCL. 50 to 70% are cured just with frontline therapy without maintenance. Maintenance therapy is not likely to cure patients, but can keep them maybe in remission a little bit longer. And lenalidomide has some positive data in maintenance of older patients based on the phase 3 REMARK trial. So this study was a phase 3 study looking at R-CHOP versus R-CHOP plus lenalidomide maintenance in older patients. So these are the patients you definitely don't want to have them relapse. They're more difficult to manage. They're older, they're frailer, they can't tolerate aggressive second-line therapy. So it makes sense a little bit to maintain these patients' remissions once you obtain that. But ultimately what we saw was that the PFS did improve with lenalidomide maintenance compared to placebo, consistent against all subgroups. Overall survival, though, was similar. So it didn't really move that needle so much, and its adoption isn't that great just because there's cost and toxicities associated with lenalidomide. As you can see, by continuing on treatment, you see higher rates of neutropenia, rash, infections, thrombocytopenia, etc. And lenalidomide, while it's pretty well tolerated, can be difficult to administer consistently at high doses for our older patients specifically. So that's the downside and why it's not widely adopted. With that said, it did have a positive progression-free survival, as you can see here. So in addition to trialing new therapy combinations, we need to understand how to improve second-line therapy options, and we do that by testing new drugs in patients who need it and need new mechanisms of action. So these therapies are now starting to move into frontline therapy, and the big class of drugs that is important to think about are bispecific antibodies. And there are many on the market. These two that are being highlighted here have kind of made the most strides in terms of potentially being clinically available outside of a clinical trial in a relatively near future, based on accelerated approvals potentially. So glofitamab is a bispecific engaging antibody. These are called BiTEs, or bispecific T-cell engaging antibodies. This one has a 2-to-1 structure. So all these bispecific antibodies in DLBCL bind CD20 and CD3. These other targets, there's a lot of other targets, but those are used in multiple myeloma, etc. But these bispecific antibodies target CD20 and CD3. And so that's important to keep in mind. And currently being used in relapse refractory DLBCL. So glofitamab has several studies. The first in human phase 1 studies in non-Hodgkin lymphomas showed great response rates. 74% of patients with relapse refractory DLBCL were enrolled in that study. I'm sorry, of the 200 patients, 74% of them or so were DLBCL. The overall response rate was 41%. So again, these patients had many lines of therapy. These were kind of the worst DLBCL patients that we have to treat. They don't have a lot of other options, but gaining a 41% response rate and allowing 25% of them to get into a complete remission is pretty remarkable. And overall, while there is toxicity and CRS associated with these drugs, it's very well tolerated, actually, once you get past kind of the first month. And you can get many patients through these first few weeks, even older patients, etc., even patients that may not be CAR T-cell eligible. You can get them through it, and overall, it's a promising class of drugs. Now, there's many studies ongoing in the frontline setting, etc., looking at combinations of R-CHOP as well as polatuzumab R-CHP for younger patients, etc. So we're going to add on to our standard therapies now and see if we can continue to improve outcomes. Mosunetuzumab is another bispecific antibody Again, a CD20, CD3 binding antibody, again, promising efficacy, safety profile, and now also being studied in frontline therapy with CHOP in ongoing clinical trials. So this one study that looked at combination with R-CHOP, a small phase 1/2 study with 36 patients, overall response rates 96%, CR rates 85% in the DLBCL patients. Overall very safe. Again, cytokine release syndrome we see, but it's very tolerated. We know when it's going to happen. We've got drugs to manage it. And comparatively to CAR T cell, dramatically different severe CRS rates. This is something that most patients are not going to an ICU. Most patients are not having neurological deficits. And overall, I've treated 84-year-old patients and older with these bispecific antibodies, and patients have done very well. You can get them through it. And again, it's very, very effective for patients that don't have a lot of other options. So in the last 10 minutes, we'll be able to do our post-test here. This is just to summarize. R-CHOP is found to be inadequate in about 30 to 40% of patients with DLBCL. 10-year overall survival rates are around 44%, receiving R-CHOP as frontline therapy alone. And in patients requiring second-line treatment, treatment costs after relapse are astronomical and are probably only going to increase as CAR T cell and bispecific antibodies are now creeping into that space. And so why it's so important to potentially, if we have to, spend more money in the frontline setting in order to cure as many patients as possible. Studies continue to evaluate alternative frontline therapies and currently studied interventions show promising activity, specifically those with consolidative radiation therapy for advanced stage disease with PET positive disease, as well as those with lenalidomide and polatuzumab. Experimental agents are now creeping into the frontline setting, particularly bispecific antibodies, and patients with relapse disease can still be cured, but our best shot is up front, and we need to continue to work on how to figure out to improve that cure rate of those patients who fail.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and most importantly for the patients you serve. Please proceed to the link in the show notes to complete the activity evaluation and claim your CE credit. Thank you.